now everyone's just gotten so busy.
All right, that time passed faster than we thought. I ask everybody to take their seats? We can start the policy roundtable.
Replacement surgeries on Coumadin, so they
exactly. All right.
She's 80 years old.
It's a challenge.
All right, so I think we've got everybody except for Stuart.
Couldn't keep it all.
Because I'm one of the regional leads.
Do we have the, nice, please, right. Do we have the names? Perfect. Yeah, you can just leave that up.
A lot of people are going to be about 2 minutes first.
All right, we are going to go ahead and get started so we can have enough time to do justice.
I'm
After you?
Orange County,
All right.
but everybody else in our team is going to talk.
So we have, can I ask the folks in the back to take their seats, please? So we have a couple of new members of the group that I'd like to introduce as they join the policy roundtable. And the names and affiliations are all up there, but again, just to kind of briefly introduce yourself, the new folks include Martin. You want to start with? Yeah, please, go ahead and introduce yourself.
Martin Zagari. I'm the head of Global Health Economics at Amgen. I've been there for about 12 years. And as the disclosures say, I'm an officer, a stockholder, and an employee of Amgen.
Thank you. Shireen.
Well, hi, I'm Shireen Fatemi. I'm from Kaiser Permanente, and I'm one of the regional co-leads for our osteoporosis program, and I'm the national clinical lead for the guidelines, and I don't have anything interesting to disclose.
Oh, we'll be the judge of that. You never know. And I'll just state that you've never had this happen before, but you work with Kaiser Permanente, but in some ways we will treat you as a representative of the payer perspective, right? So you don't work for the Kaiser Health Plan, you work for Permanente.
I'm actually one of the partners of the Southern California Permanente Medical Group,
right.
And we contract with Kaiser Foundation.
Right. All right, so we've got the large cast. Thank you for the tight quarters, sorry about that. But and you guys remember John from the manufacturer discussion. Victoria, introduce yourself.
Hi, I'm Victoria Dang. I work for United Healthcare.
Actually, it's working.
I probably don't need that.
You don't need to move there.
I have 2 young children, so I can yell. But I'm the director of program performance, which means we're responsible for the formulary development, which drugs go on which tier, what kind of drug policy coverage on what particular drugs, what the drug policy coverage looks like. Our Optum counterparts really do the brunt of the work in developing them, but we have oversight from the United perspective. So I'm representing the payer.
All right, thanks. All right, we have a lot of people, all of whom I will want to hear from, and so I'll try to be kind of quick. There's some really obvious targets we want to shoot for here in terms of, we want to talk about coverage policy. How would payers listening to the clinical experts, hearing the evidence, how would they put that together to create coverage criteria for the newer drugs? As part of that, we'll want to talk about high risk. We'll come back to that question of if we want to talk about a segment of the population for whom a certain treatment option is best indicated, how do we identify that? How do we administer that kind of thing? And we'll talk about other aspects of the research that's needed. But I would like to start again with the patient's perspective. Sometimes we reach this point of the meeting, and there's been a lot of talk about curves and p-values and ICERs and QALYs. Do you feel like we are getting close to talking about these issues from a perspective that feels like we're capturing the patient experience?
It's been a wonderful educational experience for me. But when it comes back to the numbers, which you're trying to decipher here, I have very little input because I have been extremely fortunate with the fact that I have, as a secondary insurance company, TRICARE for Life, which has picked up all the costs of all the treatments that I have had to undertake. So from that perspective, I can't really, offer a lot to this path.
All right. Well, as we talk about certainly insurance coverage, I want you not just to obviously think from your own perspective, but as a patient, help us think broadly about the different aspects of insurance and out-of-pockets and everything else that you think we should make sure we capture for our discussion?
All I can say is that these drugs are phenomenally expensive and can be an unbelievable burden to somebody's finances, especially at this point in our lives where we're on fixed income. And every little bit, when you're on a strict budget, it really can alter the quality of life.
Okay, well, thanks. We'll come back to that too. And for the CTAF panel, as always, a lot of the questions and discussion will focus up there, but if you guys want to jump in, let me see your hand or put up your name card if I can help you get in. Okay, so one way at least to approach this is to start with the payers. So I'd be curious if you can share with us, currently, teriparatide has been obviously in practice and use for many years. How do insurers cover this? And obviously you'll know your own coverage best, but as a reflection of how you think about the evidence and how you think it has been used so far to cover these agents, what's been the experience and what do you know about others? Victoria, can I start with you?
First and foremost, and this is my first CTAF meeting, so thank you very much to the ICER team for inviting me. I appreciate it. I've learned a lot from the discussions here. I can speak primarily for our Medicare policies, our Part D policies. I cannot speak to our commercial benefit or our community and state or Medicaid benefits. They do have slightly different coverage policies than we do. With regards to Forteo, we've had that drug on formulary ever since I think I can remember inception of Part D, which is 2006. The drug is on formulary. We have developed the guidelines in a manner that mirrors whatever AACE recommends. So our P&T committee is comprised of physicians who are practicing as well as pharmacists who review the literature, the cost-benefit analyses, all of that, and make recommendations. So we have a lot to consider as we write our coverage policies. However, we write them most reflective of what clinicians are practicing or utilizing today in the real world. So, for example, currently our Forteo guideline would allow for an approval if a member is considered high risk. So they have a T-score of negative 3.5 with no fractures in history, with really no trial failure of a previous bisphosphonate, we would cover. Anyone who is between a negative 1 and 2.5, we would cover if there is a history of trial failure of bisphosphonate, and we leave failure to be defined by the clinician, by the physician. Or they've had a fracture, so negative 1 to negative 2.5 with a history of fracture. Anybody who's less than a negative 0.1, more than a negative 0.1, if their FRAX score are high, then we would cover Forteo for them as well.
Okay, so just so I understood, so if their T-score is less than minus 3.5, even if they haven't had a fracture,
Correct.
even if they haven't been on a bisphosphonate before,
Correct.
they can use an anabolic.
We would cover that, yeah, for our
Okay.
Part D population. I believe our commercial benefit closely mirrors that. I think our Medicaid benefit requires trial of a bisphosphonate or Prolia. So with regards to just an example, I know the AACE released their revised guidelines just December 2016. So for 2018, our criteria, because we have to file with Medicare and also they need to approve our criteria, that's one of also the primary reasons why we mirror these societies and what they recommend more than take into consideration kind of the economic costs. Our 2018 criteria for Forteo will likely reflect AACE, where it's a negative 2.5 or lower T-score with a history of a fracture or a history of failure on bisphosphonate would get Forteo.
All right. So with the new agent, abaloparatide, how does a health plan think of kind of weaving that into its coverage? And now you've got a drug with very similar mechanism of action. We've talked about the evidence. At least the panel voted that there wasn't enough evidence to distinguish among the two as far as their clinical benefits. What kind of process does that trigger inside your system?
Inside our organization, primarily when the drug is going to be required to be reviewed by CMS, which we believe will be soon, we have, first of all, we would follow whatever our P&T recommends. So for example, if our P&T says teriparatide will be an essential drug, you have to put it on your formulary, then we have to cover it. So they'll review Tymlos, abaloterapide, and likely we think they will indicate that is not going to be an essential drug, meaning because Forteo is available now, they'll leave the choice up to the business, which would be us, to prefer one over the other or not, or place them on the same tier with the same criteria. So as we consider, I think now the next consideration would be what does the efficacy look like between the two drugs as we write the guidelines. And then also the cost of the drugs to the plan as well as the cost to the member. Because our Part D coverage, we have tiers with different copays. So if the cost of the drug is relatively, one higher than the other, then copays may be different for a member. We take cost into consideration.
Okay.
Yeah, so efficacy, it's P&T designation, efficacy, and cost.
Okay. And we'll circle back to the cost issue in a variety of different ways. Shireen,
Yes.
how does it differ or resemble the same process for you all?
Right, well, we've got 4.2 million members, and they're Medicare, commercial, self-pay, and Medi-Cal. And so we have formulary agents, and we have preferred formulary and alternate formulary, and then non-formulary agents. But it's essentially up to the physician. And if we feel that something non-formulary is what they need, then we override that. And the members have small copays or nominal copays, or some may be a little more than others, but they're not thousands of dollars, things like that. So what we will do, if you want to know about how we make our decisions too, we have our practice guidelines, but we always individualize so that for most patients that have osteoporosis, we start on alendronate as our preferred formulary agent. If they can't tolerate that or have a contraindication to that, we will use as our alternate IV zoledronic acid. If they're intolerant to that, then we will go to our preferred or alternate agents, which would be Forteo teriparatide or Prolia denosumab. And that's generally what we do here. So
Okay.
we actually, just 2 weeks ago, we've got about 60 endocrinologists in our group, and our regional pharmacy operations present to us the evidence in a fairly unbiased manner so that we can weigh in on all the evidence. And we actually chose not to include abaloparatide to our formulary only because it doesn't have a real-world track record yet. So we're going to stay with teriparatide.
Okay. So it sounds like it was a clinician-driven process, but the internal guidelines suggest that a patient would need to try zoledronic acid and either not respond or not have kind of an adverse reaction to it before
Prior
starting
to
to an
another
anabolic
agent. Not necessarily in the sense, we do choose a bisphosphonate first, but there might be exceptions when they either can't take it or won't take it or such, and then we'll make our decision to go to an alternate agent. We used to call them first, second, and third line, but that promotes a hierarchical approach to our management, which we do not want to do. So we say preferred, non-preferred, or alternate in order to give more latitude in our clinical discretion.
Got it. So I will come back to the payers because sometimes people wonder if the way that the evidence could be used in a case like this is to require that patients use zoledronic acid or something like that before getting coverage for one of the anabolics. So we'll come back to, and there's a lot of questions about how you would either create exceptions to that or identify patients ahead of time who wouldn't need to do that course, or whether that's a wise course at all, whether we're talking about apples and oranges so far upstream that to try to require patients to go through zoledronic acid or something like that doesn't make sense. So let me come back to that from the payer perspective. Inviting the clinical experts now perhaps to chime in. Let's talk specifically about, I mean, every single insurance coverage, every single clinician is going to be using the words high risk, right? And it feels like, do we all have any idea how to define that in a way that can be useful? One option that came up was the Vero study. Do we use the eligibility criteria for the Vero study as what everybody should consider to be high risk? Or is it still so clinically nuanced that to go there is a mistake? What do we do with high risk?
If I could go back just one step, I appreciated the United Healthcare talking with us, but I want to point out, one is that the field, particularly MBHA, we no longer use minus 2.5 alone as the starting point for osteoporosis. There was a paper by Cyrus 2014, which I was a co-author, which stated that osteoporosis at the moment is really presence of fragility fracture, hip or spine fracture. So one of the problems I have in my own practice sometimes, remember about half of the people with a fragility fracture don't necessarily have a T-score below minus 2.5. And, I think I heard from Deb Cotto earlier about rapid onset. We're talking rapid review. Lisa, who's one of my patients who was here earlier on the podium, who had 5 vertebral compression fractures and was in pain and was not necessarily healing, I sampled her with Forteo for 3 months before I could get approval. I want you to understand the axis at the moment is a little problematic for me as a clinician. I have to use for my clinic a half-time person alone just to communicate with insurances. And other people who are non-specialists like myself actually will send me what's now called a anabolic consult translation. The PCP knows the patient needs the anabolic, but they don't have the staffing, and they have to send it to a specialist to deal with the insurance companies. So I'm going to ask, while we define high risk, I would encourage that we work together with the payers to develop simpler methods of communication that can happen more rapidly. And and what as you're saying in this roundtable, we need to define who this higher risk patient is, and I think that's important. If I can go now back to your question, I apologize for the digression. The higher risk patient, we actually are getting more and more data on that. We heard earlier there's some data from KMOS and other studies that actually, if you add up the severity of vertebral fractures, is one. So if you have, like, as you suggested from Vero, 2 moderates add up 1, but 1 severity at 1 serious at 3, 2 moderates, the risk goes much higher. And then if you add a non-vert, it goes higher. And then there's use of data that was presented at ASBMR last year, which means there's a whole bunch of claims data that insurance companies could use. If you look at age, you look at falls and fractures, and then you look at markers of frailty, which could include cognitive problems, use of nursing homes, et cetera, and residential facilities. Yes, I think it's possible for us to develop some algorithms or ways that we can interact better with insurance companies to define this higher risk population. And if you look at that higher risk data, for example, let's imagine a 15% threshold, you can actually do a very good job of predicting who's going to have a fracture 1 year after that first fragility fracture. It's not everyone, and I have to agree with Christine. I don't want everybody with fragility fracture and osteoporosis to go on an anabolic. I don't think we need that. We'll bankrupt the health system. We need to work together as a team, and that's a call for a research agenda to define who are the people that we think are doing it. And I think, hopefully, most clinicians are voting because they're keeping that number small right now. I said 2% or 50,000. I don't want it doubling because we have 2 or 3 new drugs. I want us to stay in there, but define who those people are and do a better job and improve outcomes.
All right, so let's pretend like we have to do that today. So we can talk about future research, that's great, but we need something that can actually be written down and administered by someone over the phone, and we'll be able to quickly say whether this patient qualifies for an anabolic. What should it look like from a clinical expert perspective? Deb?
First time I'm not clamoring for the...
No one wants the mic now, right?
Probably because I'm still thinking. And certainly age has got to be a huge factor, but it's complicated because as we get older, for sure, our risk of falling and fracture and our bone density gets lower and lower. But it doesn't necessarily indicate that we should be using the most expensive drugs to prevent the fracture. I mean, I think that's the first thing I'm thinking about. To get at quick things that someone who's just trained to try to assess if someone should qualify for treatment if a physician orders a particular drug. I mean, I think that certainly BMD has stood the test of time as being an important risk factor for future fracture. So the lower the BMD, whatever threshold that is, that would be included in the definition of high risk. As a geriatrician, most fractures, not all, have resulted from a fall. So I think including fall, we couldn't do it in fracs, but we've done it in other fracture risk calculators. Fall in the past year is very important. I do think actually the really difficult one is we're talking about increased age, low bone density, and then unstable gait. Then there's this cognitive thing that comes in that's really tough to figure in. But those are the ones who end up by costing the medical system a huge amount. And so I don't know how you assess that.
So what I'm sensing partly is the very natural tension that often arises between the way that clinicians will think about high risk from individual patient and different attributes that they could imagine clustering together. Policymakers often say, well, show me the data, right? So show the study. And the study had entrance or eligibility criteria that defined patients of this type. They had T-scores of blank. They had X number of previous fractures. In that population, I know from the evidence that treatment with this drug is better than treatment with that drug. So to me, it almost doesn't matter what high risk is, or I could call high risk what the eligibility criteria were, because at the end of the day, since I'm using the evidence to decide in which patient population I know I get a benefit, I kind of go back upstream to those eligibility criteria and I rest everything on those. Now, that you've heard from the payers that they're using the clinical guidelines from the specialty societies as the anchor. But the other anchor that payers often use are those eligibility criteria. So I wonder how we think about how to bring those different pieces together. And
We have to exclude we have to exclude for clinical trials that cognitively impaired patient. We have to exclude many of these patients we're discussing. They're not eligible for our randomized clinical trials. They've got to understand informed consent. If they have comorbidity, we can't include them in clinical trials. So our challenge, our problem is clinicians, is the RCTs. Yes, they represent some good data, but we're seeing people who are not in the RCTs. I think we can't rely strictly on that. We have to use some clinical decision-making as clinicians between our interaction with the patient and our personal estimates. And I'm encouraging that that some of the data I referred to is actually claims data from Medicare claims databases. We can actually make some guidance from there. There is actually some data who are the high-risk patients, and I would encourage we put them in some fashion into defining who are the limited number of people that should have access. We want to preserve access. It's our moral responsibility to preserve access to anabolics. We need to do that, but we just have to figure out, as we're discussing now, what's the best way of doing it, and what's the best way of communicating with insurers who those patients are.
And as I hand it off to Rita, who has a comment or a question, I also wanted to say this is also kind of makes me think about the arguments in cardiology, where it continues on today. What's high risk enough to merit treatment for your cholesterol? Same thing. High cholesterol is like a low bone mineral density score. You're at higher risk of something bad happening. How high does that risk have to go before treatment is warranted? So it'd be interesting to know if the cardiologists think that there are lessons learned from their decades-long experience with that could be shared with us today. Rita, you can do that?
Sure. I'll do that first.
Sure.
Before I make the comment I was going to make. And it's interesting you say that because I was thinking about the parallels in cardiology and our kind of screening, and I feel consistently, like I said, for osteoporosis, I mean, if it's a kind of disease that you have to have an x-ray to have, I don't call that a disease. I call that, some kind of screening. And for screening, you really want to show that what you're going to do makes people better off than they would have been if you hadn't done it. And as I said earlier, I don't think we've met that bar for the osteoporosis drugs because there aren't any. I mean, you're taking people that are asymptomatic and you're giving them a drug, and there isn't any data that they're feeling better at the end of the day because those weren't in the
trial, and I do think that it has the kind of parallels with a cardiac screening, which in general the professional societies don't endorse because again, you know, we're taking healthy people, and then you have to show that you're either going to help them live longer or feel better. That's a pretty high bar. You know, when you're taking people that feel fine, you know, you should leave them alone unless you think you're going to make them feel better. And again, you have to have patient-reported outcomes and show that they're going to feel better because of the treatment we're doing. And the other thing is that, you know, I think a lot of it is lifestyle. We talked a little bit about lifestyle, and certainly in cardiology, you get your biggest bang for the buck on lifestyle changes, which you don't need to have any kind of a screening test or a risk profile. Certainly people that are higher risk are going to benefit more, but are we not going to tell someone who's low risk to, you know, stop smoking or, you know, eat better? I don't think so. You know, I think everyone can benefit from lifestyle interventions. I think there is a higher bar when you start talking about giving medications. Aside from the cost, they all have downsides, not just in terms of side effects, but people don't like to take medications if they don't have to. And these that we're talking about do have side effects. So I think that there are parallels, and that it's important to look at risk and to look at benefit. And to me, we really haven't met that far in the osteoporosis. What I had raised my card to comment on is that I think the point of the exclusions for randomized controlled trial that Dr. Silverman mentioned is important, because I think we have way too many exclusions in randomized trials. I'd like to see randomized trials that reflect the patients I see in my office. And, you know, I don't screen them out because they have, you know, renal dysfunction or this. You know, if they can't sign consent, I don't think that's most of the people who we're excluding. We're excluding, you know, for a group that then makes it not really applicable to who I see in my office. So I would, certainly there's a role for observational data, but I would like to see randomized trials with patients that look like the ones I see.
I guess to respond to the first part of that, I would say that hypercholesterolemia is completely asymptomatic.
Yes,
You're absolutely walking around, and until you have an MI or you have some unstable angina or you have a stroke, who really cares about it? So why should we really necessarily be screening for it? You know, unless we can be doing something about it.
Well, that's, you know, well, we can talk about cholesterol another day.
Yeah,
or another month.
and also to respond, I forgot to mention, of course, I think we're actually talking about people who have been affected in terms of quality of life. I didn't simply receive her as a patient from UPenn and Utah as someone who was concerned about bone density. In fact, I tell every patient when they come to me that I don't know what your goal is, but my goal as an osteoporosis doctor is to prevent the fracture. So I really don't care so much about the surrogate outcomes if you want to know the truth. And even in geriatrician, as a geriatrician, if someone has a hip fracture, do I feel compelled to get a BMD? Well, now I'm a bone specialist, so I do feel compelled because I want to see what the treatment is doing, and that's the best. I have to have a starting point. Not always, but I'm much more inclined to order a DEXA than I would have been had I not been so focused on bone. And I agree. I'm sometimes really excited that I'm a bone doctor because I think some of the other things that people worry about, like cancer and debilitating stroke and stage 4 congestive heart failure, are really things people want to avoid. A fracture is not good, and for people who've had multiple of them, and we see that in our practice, it has a big effect on quality of life. And I would say the same thing about osteoarthritis, which is very debilitating as we get older, and just really, we don't have a lot of options to treat patients. The other thing I want to say is lifestyle, absolutely. And that gets back to another point I was thinking about with you, and when you were talking about compliance to these drugs. Honestly, if people come to see me as a patient, I put responsibility on them, and we understand we have a contract. And so not only with lifestyle changes, is that the first expectation in terms of exercise and eating healthily, but the other expectation is if you're going to invest time to come to the doctor's office and to take the resources it takes where other people are waiting, you better be invested in your treatment. And if you don't like it, then you should leave. And so if you're going to sign up for, I'm not saying that they have to take the medicine, but I'm saying you need to communicate. If you don't want to take the medicine, let me know what, I'm going to respect your decision, but that's why I have a hard time with the compliance issue and thinking about differential compliance.
Yeah, I would want to add one factor I didn't make clear in my discussion was frailty. To throw that back at our geriatric colleagues, for example, use of a assistive device in walking and the like is actually another good marker. So we have a variety of ways to assess frailty as well, and I think we're clinicians. We're very sensitive to what frailty might be, loss of muscle mass in our older patients, frequent fallers. We put that into our own personal algorithm. What we do need is, I agree, is make it more formalized so we can communicate that better to insurers. And I also agree, it's osteoporosis, you're healthy and asymptomatic until you have the fracture. And we actually, while we don't have prospective data of quality of life, and we actually have some now emerging, we actually I can tell you cross-sectionally what an SQ3 vertebral fracture is worth in terms of loss of quality. That data is available. We can actually model how much the quality of life is. But I agree, we need the perspective.
Right, but the data that's not available is the effect of the drugs on those, right? They're getting approved on morphometric fractures, which are largely asymptomatic. So we don't have that data, and that's what we need. And follow-up.
Joy, you had your...
Well, just listening to this discussion about the sort of metaphor or comparison with cardiology, I think one of the differences is here where we have sort of a mixed basket of intermediate and clinical outcomes, and that makes the whole thing feel less clear. So, in cardiology, either you have a high cholesterol or you have heart disease, and there's not, I suppose there's other things, like you could have coronary artery calcium or something. I try to pretend that doesn't exist, but in these studies even, we're seeing a mixture of, morphometric fractures, clinical vertebral fractures, other fractures, and then just the straight bone density measurement. And I think it makes it very difficult to sort of think clearly about when is which treatment most appropriate, because these medications we've been talking about today, it would seem to me a very rare situation where you would treat somebody purely preventively with something that had to be injected every day. Because I don't see the patient having a vested interest in doing that. And so I just feel like one of the calls for new research or more research needs to be more clarity about appropriate outcomes and documenting the outcomes so that we know what we're talking about.
Thank you. Paul?
So in terms of policy things that could, right now, I was intrigued by the anabolic consult. So are a lot of these drugs being prescribed by primary care physicians? Because it would seem that would be one thing you could start with and saying, until we have more data, let's limit it to the specialist.
Yeah, I think the role of the specialist is twofold. The role of the specialist is twofold. One, you're actually right, Paul. I do often say, no, this is not needed. Or I actually get consults for even bisphosphonates, but sometimes I think not needed. You just change the lifestyle. That's all you need based on your absolute fracture risk. I think that's terribly important. But then the second point is the hassle. If it is the appropriate patient, that it's too much work right now to get access for your patients. As I mentioned, one patient needs 3 months of sampling before I can get approval from her unknown insurance company. And people turn to me to deal with that hassle as a specialist. And that's the current problem. But maybe if we got a better conversation, Paul, between the specialists and the insurance companies, we made it easier to find who those people are, hopefully that access would be correct.
So, Martin, I see your sign's up, but I'm not going to come to you yet.
Yeah, no problem. I'll put it down since you saw it.
No, I saw it, and I will come back, and I know what you have to say is scintillating, and it will still be scintillating then, I promise. But I want to take the opportunity to circle back now to the payer. So we've had a difficult conversation about high risk. It's not easy. There are lots of different factors that could be considered by any clinician that would make them feel that this patient is at high or higher risk. So back to the insurance policy that has to be written, or in a sense, the internal guidance, within an integrated provider group. So I'm going to play devil's advocate. There's always pressure to save money. So there's no really crisp, identification of high risk, and even if that they are all at high risk, that there's data on zoledronic acid that this panel has decided isn't that different from the data on anabolics. So would you consider a formal requirement that they try, a parenteral anti-resorptive and fail it before getting an anabolic?
It's an interesting point you bring up because that's, like I mentioned before, from the Medicare perspective for United, we actually drafted or wrote the guidelines based on AACE, and that's not their recommendation, right? So today in our policies, we don't have that requirement, to be honest with you. And just to address Dr. Silverman's comment about the thresholds we have for the BMD and T-score. Today, our Forteo guideline actually allows for coverage when the member or the patient is between a -1 and a -2.5 with a history of a fracture, whether it's vertebral or arm or something else. So from a policy perspective, I think we try to write the guidelines to accommodate the majority of our members. If there are members who have who need an exception, for example, who have cognitive issues and need a anabolic steroid agent for some reason, we have exceptions processes based on Medicare's requirement that would allow those members to get coverage before having to be required to try a bisphosphonate. Yeah.
I just, never having honestly been part of that conversation from the insurance side at all, from the clinician side, I just imagine that being a really difficult conversation. There are no clear criteria for an exception. I could call and say, I think this patient's got cognitive difficulties. They're stumbling around the house all the time. I can just imagine it being a difficult set of conversation. The other thing I guess I wanted to focus on too is that we've been talking about risk as if it's this monolithic thing that gets higher and higher. I'm not hearing that it's not risk per se, it's that there's something different about the patients for which we should be using the anabolics as opposed to just a pure consideration of how high the risk is. Can we talk about that for a second, about whether there are clinical criteria to define, not based on risk, but on something else, patients for whom anabolics should not require, even conceptually, a trial of an IV anti-resorptive first? Are there any criteria, or is it just risk?
The ACE guidelines clearly state high-risk patients
Risk.
anabolic,
Okay.
denosumab, or ibuprofen. They don't put a priority or preface that you should use one or the other, with an alternate being oral bisphosphonate. That's the guideline.
Okay, interesting.
There is no requirement to fail one to do another.
Okay, so now, manufacturers. Oh, Matthew, did you want to?
I was going to say. So again, it comes down a little bit to the patient who's right in front of you. So say a patient I had in clinic earlier this week, young guy, he's 45, he had a T-score at the spine, lumbar spine of -5.2. He had a vertebral compression fracture. Say I have a 92-year-old woman, she had a T-score of -5.2, and she's wheelchair bound. Both have the same T-score. This guy actually has a Z-score officially. I'm much more likely to give that older patient zoledronic acid. She's 94. Her life expectancy is not going to be that long. This guy is 45. He's hopefully going to be around for 45 more years, at least 40. And, if we don't do something now to try to build bone, you're going to have a 40 plus years of really poor quality. So the question is, no one will ever put this guy in a study. He's young, he's had a vertebral compression fracture already, it was while water skiing. But nonetheless, I would like to give that guy a chance to build something up before I hit him. Again, it's the individual sitting in front of you. What are those issues? Same T-score, Z-score, but yet sort of different sort of life trajectory.
So that's a very important perspective. So for the
different patients.
No, absolutely. So, which often speaks to the difficulty of writing prior authorization criteria, because there are always exceptions, but this is a particularly difficult one when you talk about those two different types of patients. So for the manufacturers, feel free to comment on any of this, but there's been talk about everybody saying, oh, but this is just for a small, high-risk subset of patients, very small. We're here talking honestly. Your company's interest is in making that population as big as possible. You want as many doctors to use this as possible. You want as many patients to be using this as possible. You don't want this limited. to a small sliver of the small subset of high-risk patients. So how do we work with that in terms of the evidence that we need to be able to identify which patients should receive these drugs? We've heard a lot about how there's still a sense that what you need to get through the FDA leaves people really grasping at whether there's a follow-through on hip fracture, on whether there are patient-reported outcomes, more quality of life. How do you view your role, not just up to launch, but afterwards, in helping inform, in a sense, the use of your agents, acknowledging that you want it to be bigger and some people would want it to be smaller? Want to go first?
Yeah, so,
Sure.
And actually that dovetails with, a couple of comments I was going to make about risk. I mean, I think I've heard all day long that risk is a central feature and better characterization of risk is critical, right, to this population. So, I would offer that, although obviously optimists in the company, would love to see, right, the most patients who can benefit and have value from getting the product benefit from it. Ultimately, I think the question is exactly the one we came together here to answer, which is what is the value of the product? And I don't think that we have quite, gotten to, perhaps what the value is. I'm actually a physician as well as a health services researcher, and the conversations so far have been fascinating because they're really complicated, right? How do we write insurance policy? How do we, pick patients? How do we redesign the trial, paradigm to get the right patients in? But I think this is a basic question that we basically spent the last 5 hours talking about, which is what's the value of these agents? And the voting ended by essentially asking a question that was informed by clinical trials that went something like, in patients with an average annual risk of hip fracture of about 0.6%, is what I saw, are these agents useful? Which was an interesting question because when I look at, as a health services researcher, the literature on who's having hip fracture, Medicare alone, 1% of all unselected members have a hip fracture. 1%. That's actually higher than the base case in the supposed risk model that we looked at. And then when I look at Medicare data that looks at how many patients have a hip fracture after having had a previous fracture, that number is more like 10%. So I guess I'd asked ICER and LADA and others, why are we talking about a value paradigm in patients with a less than 1% risk fracture rate, or for hip fractures, when I've heard even the patients themselves say, I've had this disease for 10 years and I've had 5 fractures already, right? So I think we've miscalibrated the risk. And so I'd want to take us back to that much simpler question is how do we agree manufacturer to ICER, because we're doing many of the same things, right, as health service researchers, who we're talking about. Because I think who we're talking about as manufacturers, right, are those patients that you can actually find in the literature and study in Medicare and Medicaid, right, that are having fractures at a 5 to 10% rate every single year. And that's not who we voted on here. So, I'd love to hear from, from folks who designed the model, why we stopped at the trials rather than looking at the real world data and the real patients. And I'd love to hear from the panel what they think about voting on a less than 1% risk patient versus the 5 to 10 they're probably seeing every day. Why did we vote on that?
I can tell you briefly that we obviously work with the patients that you enroll in the studies. So that's what we do. So that's, and that's because we could say that there are higher...
The central question is the value of the treated patient, not the value of the enrolled patient. And that's where ICER, I really, we worked together for years, Steve. I was at your table when you were helping design this paradigm. And, I really want to see the value informed. As a health service researcher and a health economist, we need health economics and health service research to succeed in the United States. And it'll succeed by asking the realistic questions about who's going to be treated in the population and not just sort of saying, well, this is the best data, so we'll formulate all of our questions around the data we're most comfortable with. You got to step out of your comfort zone a little bit and find data that actually matters to who's getting treated.
Martin will have to agree to disagree.
All right.
I think that what we
Almost
hope...
every other HTA basically does it the way that I'm describing it.
Martin,
so,
I'd like you not to interrupt any further, please. As a guest at this table, we welcome your perspective, but I'd appreciate you kind of being
Oh, sorry, I thought we were
polite.
having a conversation.
No, we are.
If you were taking it back over, that's fine.
We are.
I'm fine with that.
So we basically, in terms of trying to figure out which patients, we have to try to figure out where we look for the data. David, did you want to?
Well, yeah, I was actually interested in that. So given that we did an analysis where we multiplied by 10 the risk of fracture and still didn't get cost effectiveness, I'm trying to understand what your concern was. I'm not getting it. Can you, I was listening to the numbers you were quoting. If we go 10 times higher.
Actually, Lottie said, so I'm sorry, am I interrupting or can
No.
I?
No,
So
of course
Lottie
not.
indicated that they ramped up the rate by 100%. So they went from 0.6% to 1.2%.
I'm sorry, you're absolutely right. It
And
went to 1.2 per year would be
Right,
at that point.
1.2 per year. And she indicated that a Bala would be cost effective at a rate of 2% a year. Right, and I'm suggesting that 2% a year is not off the charts. There's another thing, off the charts is what we call the patient who would get these drugs. Right, and Jeff, you said we ramped it up dramatically. Well, dramatically was 1.2%. That's not dramatic.
But
right?
for
that's not
the
even
reason I
close.
said 10 times was the
I don't know where 10
teriparatide numbers, right? So that we had to go up 1,000 or 10 times,
Right.
which would get up to 6%. So, these are very high-risk patients. Are you suggesting that that range of 1.6% of hip fractures annually, that would be, 16% over 10 years, that's not the sort of people that you're talking about as very high risk? That sounds very high risk to me, but
Sorry, I
maybe it's not.
misunderstood.
Well, over 10 years, presumably that's a 16% risk of hip fracture. As we look at all the other fractures we're talking about, we're talking, many, many fractures if you look at the model. Aren't these very high-risk patients?
I think, the problem is we can descend into what's an opinion of high risk, or we can stick with the facts, right? I can look at an analysis of Medicare, and an analysis of Medicare that looks at patients who had a prior fracture, and then says, what's their rate, their annualized rate of fracture, and it's 8 or 9%, right? So as a health service researcher.
Of what fracture, though?
So basically you do a baseline fracture, let's say they have a baseline vertebral fracture, and you ask the question, how many hip fractures do you see, and what's the annualized rate?
And you're saying annualized rate of hip fracture is 8 or 9%
Once they've had a prior fracture, yes. And
one vertebral fracture gets them an 8 or 9% risk of hip fracture?
All right, now I am going to.
So we're in the details here. So my point is a broader one. Let's put the real patient data that we're actually talking about in the model, and then have a discussion of the model. Because now we're actually talking about a hypothetical outcome from a model that actually isn't asking the relevant question. I'll stop, Steve.
Thanks. All right. So back to the issue of how can we identify and talk about risk in a way that can be applied in a kind of a system between clinicians and insurers in particular. John?
Yeah. So this is a tough question, and it's because there's multiple axes, or multiple variables, all of which are continuous, and you can get to some sweet spot and say, okay, this is high risk. So like if we could decide on a patient, let's suppose we said a 70-year-old with minus 2.5 T-score who's had a spine fracture and a non-spine fracture. To me, this would be a patient where probably anybody, the clinical experts here would all say, okay, this is an anabolic patient. Well, we can then play with those variables and say, okay, if you're older, you might not need such a low T-score. Or if you have a lower T-score, you might qualify, with a higher T-score. So basically, if we could decide on a patient, okay, we have a lot of data from our clinical trials, from observational studies, including JAMOS, the Hiroshima database. All of these studies all show similar results, that these risk factors play very well together. And if we could decide an absolute risk where we say, okay, that's anabolic, then we could come up with combinations of age, BMD, and fracture that would say, okay, that patient has that level of risk and merits anabolic therapy. So I think that would be the way to go. I would also, again, bring up the subset data that I was alluding to earlier, which shows that in patients with multiple vertebral fractures, that there's an extreme benefit, very large relative risk reduction in those patients. Also in patients with multiple vertebral fractures, a very large relative risk reduction. Also in patients with multiple non-vertebral fractures. So at extremes of risk, the anabolic therapy, I think brings a lot to the table. Now, I don't think anabolic therapies only needs to go there. I mean, but at some point, at some level of risk, if we were able to decide on it, then we could apply an absolute risk threshold for using anabolic therapy. That could be very useful.
So what kinds of research would be required to do that, though?
Well, we have all of the data. I mean, and we know how these variables play together, let's say that. So if we could decide on, say, a patient, like the one I alluded to earlier, like maybe minus 2.5, age 70, and a spine fracture.
Yeah.
Okay, if that patient would qualify, then you can look at all of the variables that would get you to that level of risk.
So the other side of the...
I think in that we also need to talk horizon, because it's also important, and we think anabolics of short-term or immediate horizons in terms of risk. As clinicians, we actually do that calculation, which will help work out, but we're based on what we think is the imminent risk. Fractures, your greatest risk is in the first year to 2 years after a fracture.
So along with risk, I mean, the other side of the coin is how much benefit are we getting at a higher risk? So at some point, let's assume that anabolics will reduce the risk of vertebral or other fractures by a certain amount, and the higher risk you have, the more clinical benefit you would see. That will always leave us with the question about value still. So how much, in a sense, are we paying in a reasonable way that aligns with that added benefit for the patients? And obviously you would say you should pay more for the highest risk patient than you would for a lower risk patient, but we don't do it that way. So a little bit about the kind of the cost out of pocket and kind of relationship of price to value here. Again, Rosalind, and maybe the clinicians know this as well, given that these are administered so differently, zoledronic acid, one time intravenous in a doctor's office, the other injectable, the out-of-pocket influence of that on your patients, what's the difference? Can you generalize across different insurers on how that affects out-of-pocket considerations?
Ours are the same. It's exactly the same. But I just wanted to comment as well
sure.
on risk.
Sure.
It's so obvious to me. And I thought I was actually here as a clinician, not a payer, but I can play both roles.
I know you're both.
But risk, when you see an 80-year-old hobble in and try to get on the DEXA scanner there, hello, it's high risk. And so what we do use, though, is if any T-score is less than -3, -3.5, that's an automatic endocrinological referral. So they see the endocrinologist right there. And if anybody has ever had a fracture, they're automatically high risk. And so we kind of look at all those factors and use common sense as well, beyond a guideline that way. But and we don't as you were saying, preclude people from an anabolic agent if they haven't had a bisphosphonate, because again, if they're extremely high risk, we may use an anabolic agent first.
But to be clear, we say any fracture, so an asymptomatic vertebral fracture makes them high risk and
The
anabolic
greatest risk for
therapy?
having a subsequent fracture is already having an initial fracture, so yes. And another real high-risk group we see a lot are younger people with vertebral fractures, for whatever reasons that might be.
Right.
That's something we haven't talked about. And oftentimes, prior to their vertebral surgery with the neurosurgeon, we will use an anabolic agent as well, because the surgical outcomes are better.
And just for my own information, because I forget, maybe this is in the report, but what % of 70-year-old women have an asymptomatic vertebral compression fracture? Anybody? 50%? So half of the women at age 70 are high risk.
Well,
So based on the observational data, you're talking about 20%.
20%, okay. No, it's just, it's the verbs, adjectives, high risk, when we're talking about 20% of the population, that's not usually what we mean by, they are high risk. We're all high risk of something at some point, but that makes it a little bit more challenging.
Again, that's where
Back to the out-of-pocket question. So I would assume, though, that for many patients, there's far less out-of-pocket if they have a one-time office visit for an infusion as opposed to a daily injectable over 12 months. So, no, I'm sorry, sir. We have to stay focused on the policy roundtable. Well, I'll ask.
Let the vast majority take place in a hospital or some other place where the expenses are tremendously great.
I'm going to try to get to that. Thank you. So how can we understand the expense to different people, to the patient and to the health system? Anybody?
I address what happens with teriparatide anyway.
Yeah.
So in terms of commercially insured patients, if they have a copayment, we have a copayment card. So that the payment for people with commercial insurance is supposed to be $4 per month if they have that. There's Part D low-income subsidy patients, and they have a low cost as well. I believe it's about $9 per month. We have a Lilly Cares program, and the patients that are below 300% of the poverty level can get the teriparatide for free. The problem is Part D beneficiary patients. So Part D, as you know, is a lot of patient sharing of cost, and we are not allowed to give them a copayment card. We would love to be able to do that, but the government prohibits it. So in terms of out-of-pocket, it seems like that's the toughest group. They have to get through the donut hole. Finally, let me mention that if somebody was paying out-of-pocket, right now, like if they're non-insured and they have too much income, they can't get the drug for free, they would have to pay the list price. And we think patients should be able to get the benefits that the health insurance companies get with the discounts and rebates and so forth, which would be lower than the list cost price.
Victoria.
I'd like to comment on cost from an insurer perspective. So basically depending upon the cost of the drug, we have criteria to put it in tiers. So tier 1 would be a generic, tier 2 would be non-preferred generic, tier 3 would be a preferred brand, tier 4 would be a non-preferred brand, and then we have our tier 5, which we call our specialty tier. That's where Forteo and possibly Timlos fall in, and that's because the cost threshold is above $600 a month for a payer. So anything that is above $600 per month, we put it into a specialty tier. Specialty drugs cost for the bulk of our population, our membership, 33% cost share, which is very expensive, compared to zoledronic acid, which is currently very inexpensive in our tier 4, so our non-preferred brand tier, and that can range anywhere from $90-something out-of-pocket costs for an infusion to, depending upon their cost sharing, to $100-something. So I think that a lot of members do weigh the cost, right, of a one-time infusion for that amount versus a 33% cost sharing on a monthly basis for Forteo. Yeah. We have LICS members who are low-income subsidized who pay $9, or for zoledronic acid, $3.30 for the infusion. So that's actually a smaller part of our membership. We insure 8.5 Medicare members under Part D, and the majority of them fall into the non-list category, so they would have to pay a 33% cost sharing for Forteo, which is at about $2,000 a month. Would be very expensive. So I think a lot of members do factor in costs, and from just the utilization data that we have in our plans, the majority of our members are on alendronate.
Right. Right. So, John, I was going to ask you to share. I mean, again, we have a certain philosophy, I guess, if you want to call it, of suggesting that if the price aligns with the added benefit to patients, we're all going to be better off. For patients, for for manufacturers ultimately, and for the health system. So, I was struck that when you look at the prices right now, at least of the existing drugs, your drug has been out the longest, but it's significantly more expensive than the new drug that uses a very similar mechanism of action. And that's the main reason why the cost effectiveness was so much worse in our analysis, was basically just because the price of your drug is so much higher. What's the dynamic in the market when people sometimes think about there being competition driving prices down, and maybe even very similar prices? Can you share? I know it's hard to sometimes to talk about the specifics of a single drug, but the dynamics of this, because we will have other entrants coming at some point, and how can we think about price aligning with value when it kind of right now it seems like there's a big step change between your drug and the other drug that, could you explain that to us?
Yeah, thanks, Steve. I'm the clinical guy, so the pricing isn't really in my comfort area. But let me just make just a few brief remarks. There's probably other people that know a lot more about this. I would say that for TEO, we look at teriparatide as a drug for the fairly severely affected patient. It is a daily injection, as we've mentioned several times today, and that in itself self-limits patients. I don't think patients are necessarily lining up to take this therapy unless they really need it. And I think I've alluded to a number of criteria that establish that the sorts of patients that would take this drug, which are fairly severely affected patients, and also to the data that shows they have a very large benefit. So with regard to your analysis, or your ICER analysis, I think if we were to think about fairly severely affected patients, if we were to think about the subset data that we have in those severely affected patients, if we were to think about Vero, which should be published any day, I think the analysis will change. I'll really look forward to seeing that. With regard to the comparative pricing, I can't really comment. I wish I could control it, but I don't.
So Martin, I'll throw a pitch to you that will have a certain curve to it. So the last time we saw a new drug in the anabolic space, it was priced at half as much as the original drug. Yours drug, when it comes through, will be priced at half of the other drug. Will we see continued fall in list price towards aligning with value to patients? What do you predict as competition in this space?
Well, that's a fairly simplistic formula that would probably get me fired very quickly. But I think it comes, obviously there's been a compelling move, right, in the space. And, I'd like to think, and we have, thought about, where the pricing came from, right, that there was scientific basis for value behind that price. And, I think that, essentially, plugging in the risk, and I won't repeat myself, at length, but I think plugging in the risk is critical. And if you believe, as even your own group believe, that the fracture rate is 2% or more, right, at that price it looks cost effective, right? And at higher risk rates it's going to be more. So, when we price the product, we're going to obviously look at the competition, we're going to look at value, and we probably, I know you'd love us to follow the formula that you put out there up front, but ultimately we're going to follow more of a value-based formula.
Well, hopefully we can see together what that would be over time.
Yeah.
We'll see about that. Let's talk a little bit, and then we're going to have a chance to go around and get some final wrap-up comments. But before we do, this talk of sequencing has come up as a really important future issue for patients and for the clinical world and for payers, obviously, too, which is as evidence develops that it may be for some patients preferential to start with an anabolic and then get to an anti-resorptive instead of the other way around. What kinds of research would be needed to really solidify that view and for which patients it's most appropriate? Do we have a sense of, are there studies like that that are obviously kind of in the works now, but what more can we do to make sure, because that's going to be, it's almost like this is cancer in some ways. We're talking about drugs where sequencing will soon be a big issue. You get them approved for the highest risk patients, and then clinicians and others wonder about using them in lower risk patients, earlier lines of therapy, what have you. So this idea of sequencing, I think, is going to be critical for this clinical area. So what kinds of research do we need to get the answers there? John, you look like you have an idea.
So the sequencing, I think it's important to think about because, if somebody's 60 years old, they have osteoporosis, they'd obviously like to live to be 85 or even beyond. So it's a long time to think about treating the patient. I think most patients that are at moderate or lower risk are not obviously going to take an anabolic therapy. So that many patients are going to start with anti-resorptives. We've raised a hypothesis based on BMD information that perhaps anabolics aren't as good after anti-resorptives. But I think what we need to do is focus back on the important outcomes, which are fractures. So in the Vero study, let me just highlight that about 70% of the patients came in on anti-resorptive therapy. They were then randomized to either switch to teriparatide or to take risedronate, which is an anti-resorptive drug. And in that setting, there was a very large reduction in vertebral fractures and clinical fractures. Non-vertebral fractures, the relative risk was 36% reduction, p-value 0.1, as I mentioned before. So we haven't really seen a decreased fracture benefit in these patients. So I think in a patient at extreme risk, it makes sense to begin with an anabolic and consolidate that bone gain with an anti-resorptive. If a patient is in much better shape, perhaps they can take an anti-resorptive, and if need arises, they can take an anabolic. So if we look at BMD, we would do anabolic first. If we look at the fracture outcomes, I think we're more reassured that we can use whichever sequence is best for the patient.
All right. You know, I'm sensitive to the time. I apologize that we did kind of fall behind a little bit earlier in the day. And some of the CTAF panel members have to leave to catch flights a little after 3:30. So what I usually do towards the end is to give each of the policy roundtable members a chance to have a final kind of conclusion. Could I ask you to do that as one sentence without semicolons? A comma is okay. But it would be hopefully something that you feel like is a clear message that you want to be kind of captured as part of the report, of the discussion, and of the kind of future work that hopefully we'll do together. So I'll give you just a second to pause and think of what your one sentence is. And I'll start with the patient. Rosalind?
With the patient, well, had I been asked 2 years ago, 2.5 years ago, you will pay $20 a month copay to take Forteo to maintain your bone density as it is now, which was a minus 3.9. For $20 a month, I'd say, yeah, heck, I'll do that, even if it stays the same. However, if I had been told you can take Forteo for $2,000 a month, would my decision have been as forthcoming as it was at $20 a month?
All right, thank you. And I will go, actually I'll start, Martin, I'll start with you and we'll go this way this time. One sentence, please. Yes.
Trial risk may be elegant, but real-world risk is relevant.
Thank you. Shireen.
One needs to look at bone quality, not just quantity, and predictive models to assess future fracture risk.
I believe we have a moral responsibility to our patients to preserve their access to anabolic therapies for those patients we clinically judge to be at higher risk.
You guys are good at one sentences. You can come back anytime. Good. Deb.
Thank you for the opportunity to participate in the panel.
You're welcome.
Recognize that there are patients that we see clinically every day who don't fit into the large studies that have been performed. And in those patients, anabolics can sometimes be quite helpful and beneficial to them and their quality of life.
John?
For the right patient, at the right time, right setting, anabolic therapy can be life-changing.
Top one, only one sentence. I think in utopia, I would like to see that every patient can have access to an anabolic agent, but cost is such a huge factor that unfortunately we can't. And as a payer, we have the extreme burden to do what's right by the patient in allowance of coverage, as well as make sure we don't bankrupt our healthcare system.
Thank you. All right, so we're going to thank you as a group in just a few minutes, but I think if you don't mind, we'll just go around the CTAF and let you guys have a last statement yourself. I'll actually grant you 2 sentences instead of 1. But I'd welcome any comments you guys have to make as we work our way around. Ralph?
All right, word salad. We learned that surrogate endpoints in cardiology and in rheumatology are not perfect and should be utilized. We should focus more on patient-reported outcomes. Truthfully, I'm amazed that there's opportunities for improvement in this area. I'll leave it at that. I would encourage the utilization of risk scores like we use in cardiology to help define the best population and to make it patient-specific. And as a registry guy, I guess there's always an opportunity to correct real-world evidence in a registry format related to these patients.
Great, thank you. Felicia?
I've been struggling with this all day because I want these drugs to work, you know, as a future post-menopausal woman myself. But I still have to ask, is it worth it? Because as an ethicist, I think our moral obligation is not just to the patient in front of us, but to make sure we are justly distributing those resources among all in society who have varying needs.
Great, thanks. Robert? Anything? Okay. Alex?
All right. I look forward to the Silverman-Cato Risk Index, which will be continuously recalibrated patient-reported outcomes over time.
Perfect.
Good. Rita, you don't have anything to say, I'm sure.
Well, as always, I agree with Ralph, my esteemed colleague Ralph, on the failure, I see, of surrogates, and really think that our jobs would be much easier here if the FDA, had higher standards before things are getting on the market, and then we wouldn't be talking about premature. And the second is, I think that we don't have time to go into it all now, but I think, coupons and rebates are kind of a way of gaming the system, and we really should look at drug prices, because I think these drug prices are just coming on the market way too high. There is not a market. We didn't address why the competition doesn't bring things down. There seems to be no relation to the sort of clinical benefit at the time of approval, and just kind of shifting costs to insurers, to private insurers, to Medicare, which I think is a lot of what's going on with the coupons and the rebates. It is not really addressing the problem we have in this country, that healthcare is just way too expensive and nobody can afford it anymore. I think we need to look at what's going on and how we can do better with what we've got. We spend a lot of money on healthcare, and I don't think we're getting those kind of returns, and I think a lot of it is related to issues we was talking about today.
All right, thank you. Bill?
Okay. I see this as a twofold. One, it's treating bone fractures and the effectiveness of these products to do that. And number two, how does this play into reducing chronic disease for osteoporosis? So the value of this and how we assess the value of the high-risk patients as part of the end game here, and is there a way perhaps to factor in a preventive use or preemptive use of these medications to reduce disease is really something I hope we can look at in the future. Thank you.
All right, thank you. Christine?
I think today we've established we need to know more about patient-centered outcomes or patient-reported outcomes. We need to know more about sequencing of medications, and we need to have a better way of defining risk. Unfortunately, what I think we're going to see is we're going to see more of the same meds without these data, and marketing to PCPs and patients, which would be the wrong way to go for a medication that might be appropriate in very high-risk individuals in an individualized manner.
Thank you. Robert?
Okay, as usual, I couldn't squeeze this into 20 minutes if I had to, so I'll try real quick anyway. I want to make sure that nobody takes this personally. I really mean it sincerely to everybody, no matter how bad I accuse you of something. I'm sorry that Lisa had to be here instead of Louis, because the Global Healthy Living Foundation there'd have been some fireworks between him and me. And unfortunately, I have to dump most of that on the manufacturers right now. I'm really damn tired of hearing that we need the real-world data, that some of the real-world data is around, and it never comes in with the damn approval trials that are submitted to FDA. I want real-world data on those people. I want it collected as part of that trial. I'm tired of the lowest bottom line, that's the minimum we have to do to get approval of the drug. I've had it with that. There's going to be eventually way too many patient advocacy organizations that make way too much rigmarole, and FDA will be required to actually mandate that. And hardly anybody wants anything more mandated on approval trials. At the very least, I hope that the patient advocate organizations and the manufacturers can start having a little more interaction with ICER beforehand, instead of just the defensive stance on everything and the gripey gripe that we get from one side or the other. Team up on it, get down in the weeds, go visit, get together, do something different if you think it's really not coming out the way it is. I am not listening anymore to, it's too early to have this meeting. It's always too early to have this meeting. That's not a thing. Everybody ought to quit saying it. And in closing, I'd like to point out that Matthew actually gave us the example of the real-world high-risk patient, which is not the one that anybody thought we were talking about here today. That 45-year-old guy clearly is going to need sequence therapy. There's just no other two ways about it. We all know it. It's a no-brainer. Don't tell me there aren't some 80-year-old women that need that sequence therapy, too. And we know we're going there. So let's get real and get up to it.
Joy?
So I've been listening to all this with sort of two different perspectives. One is very personal because I'm about to have my first DEXA scan, and I've recently had a fracture that significantly affected my quality of life, and still is a little bit. And not a fragility fracture, but nevertheless. And so I think about what do I think about taking any of these drugs personally? And I have to say, I haven't persuaded myself that I'm willing to do it, despite the fact that I can see the arguments from the provider perspective. So that's the down in the, personal, clinical, like, what about me thought. But the other thought is really thinking about all of this discussion and the difficulties we've been having figuring this out in the context of what's going on in our country at this point. So we're all sitting here while the discussions about what to do to repeal and replace the Affordable Care Act are going on. And, as a country, we haven't figured out how to pay for health care, and yet we have the most expensive health care in the world, with some people who get too much and other people who don't get enough. We're the only developed country in the world that has for-profit insurance companies. Why is that? And we're also the country in the world with the most expensive drug prices. Why is that? And I'm not seeing that, sadly, that we're making any progress toward dealing with that much bigger issue that would make these discussions, I think, a little less painful.
All right, thank you. Jeffrey?
You wanted a haiku, right, Steve?
Yes.
Future published research, patient-relevant outcomes, and new definitions of high-risk patients could help us reach different conclusions.
Well, that's a hard act to follow. I think that I really appreciate the fact that there's ongoing research to develop different drugs and different mechanisms in order to allow patients to have shared decision-making and exercise their values and preferences for what drugs they want to take and how they want to take them. And I just want to encourage that it stays at the specialty referral level in terms of prescriptions, and that there isn't widespread academic detailing at the primary care level or direct-to-consumer advertising so that these patients come in requesting it.
All right, Yolanda?
So that was a hard act to follow as well. I think one of the things that's challenging is that as we think about value and also making sure that drugs that really fit a very specialized patient population get where they're needed and not where they're not needed. The challenge is for you guys to translate what all of the clinicians know. I mean, it sounds like every one of you has an Aunt Minnie of who this patient is that you would treat with these drugs. But now what you need to do is to have data to support a descriptor of that many, so that people outside of your specialty and payers know who is that high-risk patient. Because I think at the crux of it, a lot of our discussions have been about, well, who is the patient that will actually be treated? And while the surrogates, I actually think the surrogates are meaningful, but the surrogates are meaningful because they translate into a high-risk definition. And so actually knowing that this surrogate means that you have this risk of fracture, and if you have one from column A and one from column B, one from column C, which is frankly what we've had to do in cardiology, there's a utility to that.
Thank you. Michael.
So I think I would start by saying this day has once again proven that the value proposition is a hard thing to get your arms around. And this situation, like so many others that we've discussed here, shows the promise of personalizing, treatment. Some of these treatments work in some people and some don't. And I'm struck by some of the data which, kind of portrays that. As a corollary, I'd like to say that clinician discussions with benefit managers are not discussions. They're lookup on lists, and this is what you're going to do. Okay? And patients are often left holding the bag. But I'd like to say that the discussions we have here with all stakeholders moves the conversation along towards getting to that value proposition.
Thank you. Pat.
This is my first ICER meeting, and it was fascinating. I appreciate all of the time and information you shared today, as well as all the good work that ICER did. I guess what struck me is that more than 90% of the discussion did focus on the clinical side and not the cost side, which caused me to think of 3 things I would like to see going forward. One would be a recommendation to ICER to have a panel with people from companies. I guess Victoria is the one person that could talk a little bit about the cost side of it, but have a panel talking more about the cost, how drugs are priced, why they are the way they are, get into the rebates and some of those issues, because I know that most of you said you're not qualified to do that. Second, we heard this morning of another manufacturer that went to ICER before they priced their product, purposefully so that they could find what the price point was that would create the value. You saw that we all voted low value on, or 13 of us did, for the anabolics. And then third, I would like to see some of this information pushed out publicly. I feel that we need to start educating the public, informing them about these trade-offs we're making on populations until we have the data that Jeff pointed out in his haiku. Thank you.
Thanks. Paul.
Yeah, well, I'll start by saying I was actually impressed that we filled this time with the quality of discussion going in. I thought, that things would go much more simply, but I think there were a lot of issues raised, and that was good to hear. I think my main issue, again, was the lack of patient-reported outcomes. Although I'll end on a positive note saying things I didn't hear, which I've heard in previous meetings, was that it would be unethical to go back and get those outcomes because we understand the biology and we don't need to know more. So I think we've come to a point now where we're addressing actually what is value in this patient population and who are those patients. So I'm encouraged on that point that I think we're all in agreement. We do need that data.
Great, thanks. So my main job in closing is to thank those who have participated. That includes the manufacturers, the patient groups, the clinical societies. They really worked with the ICER team for almost 8 months and shared their perspectives and their data and really helped orient our report in a variety of different ways. Here today, I'd like to acknowledge the work of the ICER research team as well. Jeff, who took the lead on the clinical work, Lotta and Greg on the modeling, and everybody else. And at the meeting today, really the Policy Roundtable plays such a critical role in how we hope to engage the public and to kind of start to have the deeper kinds of conversations. And I just really appreciate the time and thoughtfulness that you guys all put into coming today and into kind of contributing to the discussion. So first, I'd like to thank the Policy Roundtable for... And obviously, I'd like to thank CTAF. You guys are spectacular. You guys did a great job examining, critiquing, thinking through the evidence in a variety of different ways. And so I guess my very brief takeaway is that we are obviously still all on a journey in which we are trying to wrestle with the real difficulties and the uncertainty around the data when drugs are launched. It's not anyone's single fault, but in a sense, it's everybody's fault, and we have to figure out how to push the system forward, because ultimately, without that evidence on clinical effectiveness and for which patients, everything else feels like it's a bit unstable. And so we will be looking for the further evidence as it evolves, but we'll be turning this report into a final version that captures the discussion that we've had and the votes, and we'll be disseminating that and having discussions with policymakers afterwards. We will try to capture the research that's needed. We'll try to capture the ways that should reflect the leadership of patients in the design of studies and in their conduct as well, to the extent possible. And we will also talk about that central tension that others have mentioned, which is we want innovation, we want to be able to treat unmet need, and we are wrestling with how to do that in a way that's fair and affordable and basically reflects value to patients and to the system. So we hope that our report and this discussion can contribute to that. So thank you for being here in the audience and on webcast, and safe travels, and we'll put out a final report with recommendations within the next couple of weeks. Thank you. Good job.
Work with you on the silver.